This is Dr. Flock with your introductory first trimester ultrasound lecture. Learning objectives are listed here. We're going to describe standard orientation for endovaginal ultrasound, demonstrate the steps for endovaginal ultrasound, apply the University of Florida protocol for the evaluation of women with suspected ectopic pregnancy to clinical practice. We're going to identify findings associated with ectopic pregnancy and discuss their positive predictive values, and also be able to assess ultrasound images for risk of ectopic pregnancy. Let's go over endovaginal orientation first, which can be a little bit confusing at times. Here's a patient model in the standard lithotomy position. Note that the transducer indicator is pointing upwards or towards the anterior aspect of the patient. Oftentimes, if you're holding the transducer like a gun, your index finger will be resting on the trigger and your thumb will be alongside the upper part of the transducer where the transducer indicator lies. Therefore, it's easy to keep track of where your transducer indicator is pointing as long as you know where your thumb is pointing. So for sagittal images, our thumb will be pointing up, transducer indicator up, and by that I mean towards the anterior aspect of the patient. These are the images that result. Remember that the green dot correlates with the aspect of the patient that you're pointing the transducer indicator towards. Therefore, that side of the patient is anterior, the opposite side is posterior, and the area closest to the transducer is inferior because you're coming in from the inferior aspect of the patient, and opposite of that is, of course, superior. The image projects like so. Next, we'll do coronal planes. In coronal plane, we rotate the transducer indicator towards the right side. Now the green dot correlates with the right side of the patient. Opposite is left. People are commonly confused by this, but where the transducer is introduced has not changed. Therefore, the upper aspect of the screen is still inferior and the lower aspect of the screen is still superior. Again, you can imagine the image projecting like this. Next, we're going to do a quick review of the anatomy. This is the uterus in sagittal plane. Again, the transducer indicator is pointing anterior. You can see the uterus outlined here and the endometrial stripe outlined like this. This is the posterior cul-de-sac and the posterior aspect of the uterus. And this continues on to the anterior cul-de-sac of the uterus. This is the uterus in coronal plane. It is donut shaped in coronal plane. The endometrial stripe is located at the center. Posterior cul-de-sac is again behind the uterus, and anterior cul-de-sac is in front of the uterus. This is an ovary in coronal plane. Typically, adnexal evaluations are easiest in the coronal plane. In this view, for example, we're moving towards the left side of the patient. So you see the uterus here and the ovary here and iliac vessels here. The easiest way to find the ovaries is to scan out into the adnexa until you identify the iliac arteries. You're going to be just next to the uterus here, and then the iliac arteries and uterus form this 45-degree plane here. And then you're just going to scan up and down that plane, and somewhere within that plane the ovaries have to be located unless they're obscured by bowel gas. Here again with the anatomy labeled. This is sagittal plane on transabdominal imaging. The uterus is located behind the bladder, and this is the cervix and vaginal stripe. This is the uterus transabdominally in transverse plane. Again, the uterus is donut shaped, posterior cul-de-sac, anterior cul-de-sac. Let's go over how to perform an endovaginal ultrasound. First, we introduce the transducer, and then the first step is to identify the uterus. The most reliable way to identify the uterus is by lifting up on the transducer handle like this and showing the cervix, and then again dropping the transducer handle and showing the connection of the cervix to the fundus of the uterus. Now you have definitively identified this structure as the fundus of the uterus through its connection to the cervix. Once we've identified the uterus reliably, we're going to fan completely through the uterus from side to side, defining its transverse margins like this. We fan, as with any organ, until the organ comes completely in and out of view. This is a complete sweep of the uterus. Next, we'll switch planes into coronal view by rotating the indicator to the patient's right side, and then we sweep completely up and down as you see in this video, again sweeping through the entire uterus. Now we can finally focus on the intrauterine contents. We bring the gestational sac into view. We can freeze the screen when the fetus is in view. And then we can perform our measurements such as a crown rump length, as in this case. We could also turn on Doppler or M mode to record fetal heart rates. After having evaluated endometrial contents, you should look outside the uterus. First, look in the posterior cul-de-sac as well as the anterior cul-de-sac for free fluid. After that is complete, we're going to go ahead and evaluate the adnexa, sweep out into the adnexa and through the ovaries, looking especially for heterogeneous masses and tubal rings around the ovaries. Again, more on these types of pathologies later. So to review, the first step is to identify the uterus. The second step is to look inside the uterus to identify gestational sac and yolk sac. The third step is to look outside of the uterus for free fluid and tubal rings or other adnexal masses. Let's cover a couple of definitions. An intrauterine pregnancy is defined as a fundal gestational sac over 5 millimeters surrounded by a thick concentric echogenic ring containing a yolk sac or fetal pole. So by this definition, we cannot call a reliable intrauterine pregnancy unless a yolk sac is clearly visualized. Please keep this in mind. An abnormal intrauterine pregnancy is one that has a gestational sac greater than 1 centimeter without a yolk sac, or a gestational sac greater than 16 millimeters without a fetal pole, or a fetal pole greater than 5 millimeters without fetal cardiac activity. An ectopic pregnancy is a gestational sac which is surrounded by a thick concentric echogenic ring containing a yolk sac or fetal pole outside of the fundus of the uterus. All other findings are classified as an NDIUP or no definitive intrauterine pregnancy. Let's take a view at some common ultrasound findings and their associated risk of ectopic pregnancy. Keep in mind that all NDIUPs are associated with approximately a 20 to 25% chance of ectopic pregnancy. That is actually very high if you think about it. That means every time you don't clearly visualize an intrauterine pregnancy, a quarter of those women will go on to have an ectopic pregnancy. Any free fluid increases the chance to 52%. A complex adnexal mass is highly suggestive of an ectopic pregnancy, 75%. Moderate to large free pelvic fluid indicating a ruptured ectopic is at 86%. Echogenic free fluid, which quite frankly basically is what blood looks like, further increases the risk to 86 to 93%. A tubal ring is highly specific at 95%. Mass and free fluid are at 97%, and right upper quadrant free fluid with an empty uterus is 100% specific for ectopic pregnancy. So what's it mean when we say large free pelvic fluid? Let's take a look at this. A small amount of free pelvic fluid is defined as going up less than 1/3 of the posterior aspect of the cul-de-sac. Moderate free pelvic fluid goes up between 1/3 and 2/3 of the posterior cul-de-sac, whereas large free pelvic fluid extends greater than 2/3 up the posterior cul-de-sac, or is free floating between bowel loops in the anterior cul-de-sac or extra pelvic regions, such as having a positive FAST exam. Let's take a look at our diagnostic protocol. In any woman in whom you suspect ectopic pregnancy, which is all women of childbearing age which present with abdominal pain, vaginal bleeding, lightheadedness, syncope, painful sexual intercourse, nausea, shoulder pain, or any other clinical concern, The first step is, of course, to obtain a urine pregnancy test. If the urine pregnancy test is negative, then ectopic pregnancy is ruled out for all intensive purposes. If the urine pregnancy test is positive, the next step is to perform an endovaginal ultrasound for further risk stratification. There's a misconception that prior to performing the ultrasound, an HCG needs to be resulted. An even more dangerous misconception is the one that states that if a HCG is obtained and it is below the discriminatory zone of 1500, then no endovaginal ultrasound is necessary. This is a very dangerous, outdated concept that will lead to many ectopic pregnancies being missed, as we will see later. I just want to emphasize that at this point so that if you hear people suggesting this, you can firmly resist the temptation and go ahead with your endovaginal ultrasound. And there's one of four things we're going to find. Most commonly, in fact 70% of the time, we're going to find an intrauterine pregnancy. At that point, unless the patient has undergone assisted reproductive technology, ectopic pregnancy is ruled out, because heterotopic pregnancy is extremely rare. If the patient has undergone assisted reproductive technology, such as in vitro fertilization, then you should consult obstetrics or speak with their reproductive endocrinologist. If you find an abnormal intrauterine pregnancy or an ectopic pregnancy, then of course we're going to consult obstetrics. If we do not find a definitive intrauterine pregnancy, but we also do not see an ectopic, then the pregnancy is classified as no definitive intrauterine pregnancy. At that point, the next step is to actually obtain a quantitative HCG. If the quant is greater than 1500, above the discriminatory zone, then an intrauterine pregnancy should already be easily visualized and OB consultation is indicated. If the quantitative HCG is less than 1500, at that point, further risk stratification is necessary. Many of these patients may just have an early intrauterine pregnancy, and if they have no high-risk findings, we have low clinical suspicion, and they can safely follow up with OB at 48 to 72 hours to recheck their HCG to ensure appropriate rise. However, it is important to instruct the patient that if for any reason their OB follow-up falls through, they come back to the emergency department in that same time frame for repeat examination and repeat quant. This can most commonly happen if their recheck date falls on a weekend or a holiday. If we do find high-risk findings, then we have high clinical suspicion and OB consultation is obtained. When should you have high clinical suspicion? Most importantly, for high-risk ultrasound findings, such as a complex adnexal mass, moderate to large free pelvic fluid, echogenic free pelvic fluid, a tubal ring, an adnexal mass and free fluid, or free fluid in the right upper quadrant. But also, of course, if the patient appears unstable with unstable vital signs or has peritonitis on physical exam, then again, OB consultation is indicated. So, please follow this protocol for all your patients with suspected ectopic pregnancy to minimize their risk of complication and the risk of missed ectopic pregnancy. Let's review some pearls from the literature. So as far as epidemiology is concerned, the general population has an ectopic pregnancy rate of about 2%. However, in the emergency department, that incidence goes up to 8% of pregnant patients. That's a huge amount. Let's take a look at the published locations of ectopic pregnancies to expect what to find when we do our ultrasound. Most ectopic pregnancies are located in the tube, approximately 97% of them. However, 3% will be located in either the ovary, cervix, interstitium, or intra-abdominally. While rare, this can happen and therefore something we need to be aware of. ED protocols for excluding ectopic pregnancy through confirming intrauterine pregnancy can reduce the incidence of ruptured ectopic pregnancy by 41%. That's an absolute risk reduction. That's a huge number. So following the protocol that we've laid in place here will greatly benefit your patient. The literature also tells us that when emergency physicians use a double decidual sac sign alone as definitive proof for intrauterine pregnancy, they miss up to 10% of ectopic pregnancies. Obviously, this rate is unacceptably high, which is where you see the discrepancy in practice between emergency medicine and obstetrics. This is why we do not call a definitive intrauterine pregnancy unless a yolk sac is present, whereas many obstetricians and radiologists may be comfortable doing it a little bit earlier in pregnancy when only a double decidual sac sign is visualized. There are relatively few patients that fall into this gray zone, and OB consultation is appropriate for them. It is justified to ensure that our ectopic miss rate is low. I've already told you that there's no safe cutoff for quantitative HCG that excludes ectopic pregnancy. Now I'm going to tell you why. This is data from a couple different studies showing the proportion of ectopics with quants less than 2,000. So if we decided to only perform ultrasounds if the quant is over 2,000, we would miss 44% of ectopics. Similarly, if we used 1,000 as a cutoff, again a much lower value, we'd still be missing over a third of ectopics. Again, this miss rate is unacceptably high, which is why there is no safe cutoff for the HCG to determine that we do not need an endovaginal ultrasound. Positive HCG and a positive right upper quadrant fast pretty much means that you're dealing with an ectopic pregnancy as long as the uterus is empty. If the uterus does have an intrauterine pregnancy in place, it is more likely to be a ruptured ovarian hemorrhagic cyst. The positive right upper quadrant fast in the setting of ectopic pregnancy predicts the need for operative intervention with a positive likelihood ratio of 112. Again, this is a huge number. This study sheds some light onto the limited usefulness of some commonly utilized clinical variables in risk stratifying patients with ectopic pregnancy for the need for operative intervention. We already know that ultrasound can give us some useful information with respect to the need for operative intervention. But the most interesting part is the lack of difference between women requiring operative intervention and those that do not with respect to estimated gestational age, pain scores, heart rate, systolic blood pressure, shock index, and even hemoglobin. This study by Tayal shows what typically happens when a diagnostic protocol like ours is utilized. In this study, they enrolled 1,500 patients with suspected ectopic pregnancy and risk stratified by ultrasound. Like we've already talked about, 70% of these women were diagnosed with intrauterine pregnancy and discharged home safely. The remaining 30% will result mostly in OB consult for things such as embryonic demise, molar pregnancy, and ectopic pregnancy. About 20% of patients in this study were diagnosed with no definitive intrauterine pregnancy. Of those 20%, 3% were lost to follow-up, and in this study, 15% of ND-IUPs resulted in ectopic pregnancy, whereas 53% resulted in miscarriage, and only 29% turned out to be viable intrauterine pregnancies. Alright, finally we can have some fun and get into some cases. Case 1. Take a look at the image here. We'll go over some anatomy. Here is the cervix, will be located about here, and that connects to the fundus here. And then within the fundus, we see a double decidual sac sign, and a gestational sac, and a yolk sac with an attached fetal pole that appears to have a heart rate. Here's the same thing in coronal plane. Again, bladder is here. Now we have a donut-shaped uterus with a double decidual sac sign and a fetal pole with a yolk sac within it. So our diagnosis is definitive intrauterine pregnancy, which appears to be alive. The next management step is discharge home with routine OB follow-up. So what are the order of ultrasound findings with intrauterine pregnancy? They proceed from double decidual sign to gestational sac to yolk sac, which, as we've discussed, is the earliest definitive finding of intrauterine pregnancy, to fetal pole, to fetal cardiac activity. And what's the associated timing? Basically, the findings begin at 4 to 4.5 weeks with double decidual sign, and then proceed in half-week increments. So the next, as we've already discussed, is gestational sac, and again, that now starts as 4.5 to 5 weeks. The next is yolk sac, again at 5 to 5.5 weeks. Next is fetal pole at 5.5 to 6 weeks. Next is fetal cardiac activity at 6 to 6.5 weeks. All right, let's take a look at case 2. I'll give you just a second to get your bearings here. Try to identify the uterus and its connection to the cervix. Remember, showing this connection is the most important thing for reliably identifying the uterus. So again, here's the fundus, and it connects to the cervix right here. I just swept out of view. Right here's the connection to the cervix. So we know for sure that this structure is the uterus. Right here. We do not see anything located within the uterus. And so next we're going to look outside the uterus for free fluid. And I do not see any free fluid in the anterior cul-de-sac and the posterior cul-de-sac. Same thing in coronal plane. Here's the uterus. Here's the endometrium. We don't see any free pelvic fluid. There does appear to be a small fluid-filled structure in this left horn of the uterus. Right here. Is that a gestational sac? Well, it does not contain a yolk sac, so we cannot call it a gestational sac yet. Let's take a more detailed look outside the uterus. Here we're panning into the left adnexa. And within the left adnexa, we find a tubal ring, a bright white echogenic ring containing a gestational sac, a fetal pole with cardiac activity, and a yolk sac. Here's a sweep through the left ovary. By comparison, we see normal ovarian tissue and a corpus luteum cyst. The main differentiating characteristic between a corpus luteum cyst and a tubal ring is that the corpus luteum cyst does not have a bright white echogenic ring around it. Here's another sweep into the left adnexa in sagittal plane showing the ectopic pregnancy. Next, let's compare the tubal ring to the corpus luteum cyst in coronal plane. Here we see the ovary with corpus luteum cyst up here, and then we sweep into the ectopic pregnancy and the tubal ring. So, no bright white ring, bright white ring. So our diagnosis is ectopic pregnancy, which happens to be alive. Let's review the anatomy real quick. Again, here we have the cervix connecting to the fundus, containing the endometrium. Here's the adnexa with a tubal ring, a yolk sac, and a fetus. Here's another look at that pseudosac. A pseudosac is merely a blood-filled portion of the endometrium and not a true gestational sac. So what percentage of the time are we actually able to directly diagnose an ectopic pregnancy? It's only 15% of the time. That means the vast majority of the time we diagnose ectopic pregnancy through inference, meaning through high-risk ultrasound findings such as free fluid, adnexal masses, tubal rings, or through laboratory evidence such as lack of appropriate rise of the beta-HCG. So here's another look at that perfectly visualized ectopic pregnancy. All right, case 3. So here we're seeing the bladder and uterus on a transabdominal ultrasound. Again, this is sagittal plane. connects to the cervix right here. Vaginal stripe is seen right here. Within the uterus, we see a thickened endometrium, and we see some fluid, so possibly a gestational sac, but certainly no yolk sac within it, so we do not see a definitive intrauterine pregnancy. Same thing in transverse plane. Take a look at that. Bladder here. Really all we're seeing is a thickened endometrium with some gestational sac fluid around it. So what's the diagnosis? Well, we already said at best it's no definitive intrauterine pregnancy. But what if I told you that the beta HCG was greater than 80,000? That's right. It's a molar pregnancy. Case 4. Back to endovaginal ultrasound. We're looking at a uterus in sagittal plane. Here's that connection to the cervix that is most important to visualize in order for us to call this the fundus of the uterus. Now that we know that this is the fundus of the uterus, let's just look at that once as we pan through it. I do not see a gestational sac or a yolk sac within it. And now, fanning into the adnexa, we see a complex adnexal mass. We're calling it a complex adnexal mass. Complex means heterogeneous in this case. So meaning it has some solid components, some hyperechoic components, some hypoechoic components, and some cystic components or fluid-filled components. We cannot be sure about what this mass is. However, we do know that the evidence suggests that these masses are associated with ectopic pregnancy. Therefore, the diagnosis is no definitive intrauterine pregnancy, but at very high risk for ectopic pregnancy, so an OB consult is mandatory. Case 5. We're back to transabdominal ultrasound. You've already guessed it, we're starting in sagittal plane. Here's the fundus. Here's the cervix, vaginal stripe, bladder. Looking inside the uterus first, we see a double decidual sign and we see a small sac. However, there's no yolk sac within it, so we are not going to call this a definitive intrauterine pregnancy at this point. Bladder, donut-shaped uterus, again with a double decidual sign, this time in transverse plane. No yolk sac within it, so ND-IUP so far. The gestational sac size correlates with a 5-week pregnancy. So of course in this setting, if we're unable to visualize an intrauterine pregnancy on transabdominal ultrasound, the next step is to perform an endovaginal ultrasound, which is what we did in this patient. However, it does not look like this yields any additional information. Here's the cervix, here's the fundus, and we do see again a double decidual sign within it, but no yolk sac. Again, it correlates with a 5-week intrauterine pregnancy. So our diagnosis is again no definitive intrauterine pregnancy. However, with an HCG less than 1500 and no high-risk findings, this patient is clearly safe for OB follow-up in 48 to 72 hours. Case 6. We are performing an endovaginal ultrasound. We see the uterus here. We see a double decidual sac sign. We do not see any yolk sac or fetal pole within it. Therefore, the diagnosis is an anembryonic gestation, also known as a blighted ovum. So again, we see the uterus here. We see the endometrium here, a double decidual sac sign, and no fetal pole within it. This is an abnormal intrauterine pregnancy. Therefore, OB consultation is necessary. Case 7. Again, we're performing an endovaginal ultrasound, and we see the fundus of the uterus here and the cervix here. Small free pelvic fluid would be to about here, moderate to about here. And this pelvic fluid is all the way up to here and even in the anterior cul-de-sac here. So we see a large amount of free pelvic fluid, and when panning out into the adnexa, we see some solid components, some concerning masses. This is a still of the mass we saw there. Again, concerning, but not diagnostic. So our diagnosis is once again no definitive intrauterine pregnancy. However, at very, very high risk for ectopic pregnancy, the large free fluid alone gives it an 86% chance of ectopic pregnancy, and when you add the mass to it, that takes it up to 97%. So this patient went to the operating room and had an ectopic pregnancy diagnosed. Again, reviewing the anatomy. Bladder is compressed up here. This is not the bladder. This is fluid in the anti-cul-de-sac. This is the empty uterus. Cervix is here. Remember, the connection of the cervix to the uterus is what definitively identifies the structure as the uterus. The posterior cul-de-sac is here. Fluid up to here would be small. Fluid up to here would be moderate. And above this is considered large. There's some bowel gas in the background here. Free fluid all around it. This patient also had an associated positive FAST exam. Kidney, liver, stripe of free fluid in Morrison's pouch, which is both diagnostic of ectopic pregnancy as well as a strong marker for the need for operative intervention. Another life saved. On we go. Case 8. We're once again performing an endovaginal ultrasound. I hope you saw the uterus coming in and out of you here already. Here's the cervix connecting to the fundus. We do not see anything definitively within the uterus here. So far I would call this an ND-IUP. Let's look outside the uterus to further stratify. There's a little bit of free fluid back here. And there's a mass-looking structure there. Let's get a closer look at that. Here's again a still. Cervix, fundus, endometrium. Maybe there's an early gestational sac or a pseudosac, but certainly no yolk sac within it. And here's a look into the adnexa. This is not really hyperechoic, so it's not a tubal ring. It's also contiguous with the ovary, so likely represents a corpus luteum cyst. Right here is normal ovarian tissue. Some free fluid adjacent. Same in coronal plane. Again, we see the uterus here and that ovary containing the corpus luteum cyst there. So diagnosis is ND-IUP. In the right clinical context, if the patient is stable and has a low HCG, she's potentially safe for 48 to 72 hour follow-up with OB. Case 9. Okay, that looks boring already. There's a cervix here, connecting to the fundus there. Anterior cul-de-sac, posterior cul-de-sac, small amount of free fluid, double decidual sac sign, yolk sac. That's the definitive intrauterine pregnancy. When we blow that up and put it in live motion, again we see a double decidual sac sign, a yolk sac, and a small fetal pole with cardiac activity. This is also called a diamond ring sign because it looks like an engagement ring, where the 2-carat diamond is the fetal pole. So diagnosis again is definitive intrauterine pregnancy. Patient is safe for discharge home and routine follow-up with OB. So here's our uterus, endometrial stripe here, double decidual sac sign, gestational sac, yolk sac. Again, blown up, same thing. All right. Case 10. All right, endovaginal ultrasound, bladder, cervix, anteverted uterus with a fundus. Just switch to coronal plane, scanning up and down, And we're starting to see something over here that looks a little bit suspicious, like that's not what things usually look like. And when we blow it up a little bit, we see something that looks like a gestational sac. We think it's a gestational sac because it contains a fetus, and it has a bright white tubal ring around it, or an echogenic decidual reaction around it. This one's actually not located within the tube. We can also kind of see that the endometrium points towards this lesion. It does not contain this lesion, it points towards it. Let's look at that again right here. See that endometrium not surrounding the lesion but pointing towards it. So diagnosis is a cornuate pregnancy or interstitial pregnancy. Here we see the pointing endometrium, also known as interstitial line sign. We have an interstitial line pointing towards the cornuate pregnancy. So remember the pointing endometrium as a sign of ectopic pregnancy, specifically a cornuate pregnancy. All right. We also have a lack of myometrium encircling the gestational sac. As you can see, the myometrium is over here, and there's almost no myometrium around the cornuate pregnancy. So ultrasound criteria for an IUP are decidual reaction, gestational sac, and yolk sac within the endometrium, not next to it. All right, next case. Case 11. We're doing our sweep through the uterus here, cervix there, so we know for sure that this is the uterus. See the endometrial stripe there. There's nothing inside of the uterus. Looking outside the uterus, there appears to be some free fluid, free floating between bowel loops. So I would therefore classify that as large free fluid. Same thing in coronal plane. Scanning through the uterus here, we're not seeing anything within it. We're seeing some large free fluid. Anything else catch your eye? Well, in this coronal sweep, we also see a ring right here, a bright white ring, a tubal ring. Let's take a closer look at that. Here's the ovary. It is not contiguous with this ring. This ring is not within the ovary. It does not appear to be a corpus luteum cyst. It's also surrounded by a bright white echogenic ring, so this is a true tubal ring. It also contains a yolk sac, which makes this a definitive ectopic pregnancy. Here again we have ovary, tubal ring, uterus. Magnified, same thing, tubal ring, yolk sac within it. So diagnosis is a definitive ectopic pregnancy. So we see our empty uterus and free fluid all around it, including free floating between bowel loops and into the anterior cul-de-sac, so large free fluid. And then in the adnexa, we see the ovary here and the tubal ring there. All right. Another different angle on the tubal ring with a gestational sac and yolk sac. Another good case. Another life saved. Case 12. So here we're looking at a uterus, sweeping back and forth through it. Does that look different than the other ones we've looked at? Alright, that's actually the first retroverted uterus we've seen today. Here's the fundus pointing towards the posterior aspect of the patient. Here's the cervix, the cervical connection making this definitively the fundus. We see our standard endometrial stripe. We don't see anything within the uterus, and there's no free fluid in the posterior cul-de-sac. Same thing in coronal plane. Going really slow for some reason. Donut-shaped uterus, nothing within it, no free fluid around it, and we just have a cyst over here in the right adnexa. So diagnosis, ND-IUP, and a retroverted uterus. Looking at the anatomy again here, it's the fundus of the uterus there, endometrial stripe here, cervix, and in coronal plane we have the uterus, the endometrium, and a cyst within the ovary. So next step, this patient actually requires a quantitative HCG. If again she does not have any high-risk clinical features, it does not look like she has any high-risk ultrasound features, so if her quant is less than 1500, this patient may be a good candidate for 48 to 72 hour follow-up with OB. Next case, 13. Transabdominal ultrasound. So the anatomy is a little different. We have the bladder here, uterus there. Probably not the best view of a uterus ever. Cervix there, vaginal stripe there. And then all this here, there's not two bladders, so one of these is not the bladder. So this stuff here is all large amount of free fluid in the anterior cul-de-sac, as well as the stuff over here. That's still the same again. Uterus, cervix, vaginal stripe, bladder, large free fluid in the anterior cul-de-sac. This is what I like to call the double bubble sign. In transverse plane, a positive fast in the pelvis sometimes appears to have two bubbles, two bladders. This looks like a bladder, but it's not the bladder because this is the bladder. Even if you can't tell which one's which, you should be able to figure out that we ought not to have two bladders. One of those is an abnormality, and this patient has large free fluid. This is a positive fast exam. So our diagnosis here is in the IUP. Once again, the quant is 526. So, below the discriminatory zone, so clearly safe for discharge and followed with OB, right? Of course not. OB was consulted for high suspicion for ectopic pregnancy, secondary to the visualization of large free pelvic fluid with an empty uterus. The OB team was not too excited about admitting this patient. As you can see here from their note, an IUP wasn't seen, but her quant is low, below the discriminatory zone, so a pregnancy would not necessarily be visible at this stage. Also, it would be very unusual for the fluid to represent a ruptured ectopic, and the patient appears so stable clinically with normal vitals and labs. This statement is again factually inaccurate, considering the evidence that we have reviewed. The ultrasound classification is more reliable than clinical features such as hemoglobin and shock index. Later on, the patient did become unstable, went to the operating room, and an ectopic pregnancy was discovered, and is shown here on pathology. So once again, an HCG less than 1500 does not rule out ectopic pregnancy. Reviewing some landmarks for transabdominal ultrasound. We're looking for the bladder, cervix, and vaginal stripe. Bladder here, and an anteverted uterus. Cervix, again the connection of the cervix to the fundus identifies this as the fundus, and then the vaginal stripe here. Transabdominal findings lag behind endovaginal findings by about 1 week. Case 14. This is just a case from the literature, just a published tubal ring next to an ovary. Again, just giving you a good idea of what this looks like. We have the uterus here, the iliac vessels here, and then the ovaries and tubal rings are sandwiched just between those two. So again, in coronal plane, it's really useful to very carefully survey that 45-degree angle between the uterus and the iliacs. Case 15. Endovaginal ultrasound, sagittal plane. We see the fundus of the uterus there. Endometrial stripe here. Connection to the cervix is going to be right around here. This is probably not the best example of showing the fundus connecting to the cervix. So why am I emphasizing that so much in every case that we look at? It turns out that in most cases of missed ectopic pregnancy, what the provider did upon review of the images is they go straight to a gestational sac that contains a yolk sac, and so they say this is an intrauterine pregnancy. They never carefully fan through that structure and make sure that it's within the fundus, which connects to the cervix. So being systematic about identifying the cervix connecting to the uterus will greatly reduce your chance of missing an ectopic pregnancy. This is the same patient in coronal plane. We see a gestational sac here, so I guess we're done, right? Of course not. You guys have already figured out that we do not see a yolk sac inside of here. This could easily be a pseudosac. We are going to remain highly suspicious until we're able to visualize a yolk sac within a gestational sac. Here's another coronal sweep. This time we're able to visualize some free fluid in the anterior cul-de-sac. So that would classify as large free fluid again. Next thing we're going to do is survey the adnexa. We've identified the uterus, we've swept through the uterus appears empty. We looked outside the uterus for some free fluid, we found some, and now we're going to do our adnexal survey. Like I already told you guys, when we're surveying the left adnexa, as in this case, we're going to put the uterus on this side of the screen. Then we're going to see the iliacs on this side of the screen, like right here, and then they form basically a 45-degree angle. So once you've identified the iliacs over here and the uterus over here, this 45-degree angle is where the money's at. So just sweep up and down through that 45-degree angle, looking for tubal rings and other abnormalities. See anything here? Well, there's this big glob of stuff right there. It's difficult to describe. It has hyperechoic elements, hypoechoic elements, cystic and fluid elements. It's a heterogeneous, complex adnexal mass. We've already figured out that those are very high risk for ectopic pregnancy. But let's put some color on this one and see what happens. So here we're doing the same sweep with some color Doppler. And we can see a ring of vascular supply within that mass. This is termed a ring of fire. A ring of fire basically just represents the increased blood supply that an ectopic pregnancy stimulates around it. So just to train your eyes some more for a good adnexal evaluation, here we're looking at our adnexal sweep again. And we see the complex adnexal mass here, and then a normal ovary here, and iliacs there. Same thing when we place color on the adnexal mass, iliacs, uterus, adnexal mass, and normal ovarian tissue seen right here. So again, our diagnosis is NDIUP with extremely high risk for ectopic pregnancy based on a 97% probability of ectopic with the visualized complex adnexal mass and free fluid. Case 16. Is this ever going to end? Well, nothing teaches like repetition, guys, so we'll just keep on rolling. Here's another sweep through uterus, bladder, fundus, cervical connection. It appears empty. There's no fluid in the posterior cul-de-sac, no fluid in the anterior cul-de-sac. Here's a coronal view of the same. No free fluid here, no free fluid there. Here is a view of the left adnexa. Nothing remarkable here. Here's a view of the right adnexa, where we see some free fluid and a sac with a thick concentric ring around it. It's not hyperechoic, but it is a sac with a thick concentric ring around it, so definitely a little concerning. Then we put color Doppler on it again, and we see a ring of fire around it, making it more concerning. This patient was admitted to the hospital and received methotrexate for, once again, a diagnosis of NDIUP with very high risk for ectopic pregnancy. Alright, a couple more quick ones. Case 17. This is what echogenic free fluid looks like. Remember, this is highly suspicious for ectopic pregnancy. Case 18. This is an endocavitary view of what a molar pregnancy will look like. You see this grape-like cluster that's causing endometrial distension. Case 19. Here's another great example of a pseudosac. This is not a gestational sac. It does not contain a yolk sac. Therefore, do not be fooled into calling this an intrauterine pregnancy, because it is indeed an ectopic pregnancy. Case 20. Here we have another side-by-side view of a tubal ring and a corpus luteum cyst. Hyperechoic, not hyperechoic. Case 21. Here we see an ovary adjacent to a complex adnexal mass. Again, we call this a complex heterogeneous adnexal mass because it has hyperechoic components, hypoechoic components, and anechoic fluid-filled cystic components. Case 22. Another ring of fire published in the literature. This can be associated with both ectopic pregnancy, as in this case, or with a hemorrhagic ovarian cyst. Case 23. Here we have another complex adnexal mass, tubal ring in a mass which has both hypoechoic and hyperechoic components. Therefore, it's a heterogeneous mass with some free fluid around it, highly concerning for ectopic pregnancy. Last case, case 24. Here we have a perfect example of that cervical to fundal connection, proving this as the uterus, endometrial stripe, large free pelvic fluid around it. That sure looks like ectopic pregnancy. And then when we sweep through it, again, we see the endometrium is distended. This is a perfect example of a pseudosac. Do not be fooled into thinking that this is an intrauterine pregnancy. If there's no yolk sac, it is not an IUP. Here's the right adnexal view for that case. Here's the left adnexa with some free fluid around it, and again, perfect example of a pseudosac associated with ectopic pregnancy. When we measure it, it even looks like it could be a 7-week, 3-day pregnancy, but again, without that yolk sac, it is not an intrauterine pregnancy. So diagnosis, ND-IUP with very, very high risk of ectopic pregnancy, needs to be admitted to obstetrics. So that's all I have for you today. Thanks for listening. Write down any questions you may have at this point and we'll talk about them during our hands-on session. See you guys then.